All right. So 2 weeks ago, we talked about continuum-based thinking versus black and white thinking. That was this broad principle, which I think really, to me, makes up the foundation of what I want to get across in this collaboration of looking at how we bridge the gap from physical therapy and other movement professions. And we have to kind of think a little bit more outside the box in the gray, but look at things like a spectrum. So to take that concept a little bit farther today, I want to look at the idea of structural diagnosis, which is sort of a framework of what we look at as physical therapists for what we're treating. And I know, at least when I was in school a long time ago, that was the basis of what our orthopedic and neurological education was. We had to understand structural diagnoses, things like rotator cuff tears. We had to understand herniated discs. Everything had a label to it. And when you look at the healthcare model with ICD-10 codes, you still have to have those labels in order to really have the right to treat anybody. And it's within our Practice Act now that, basically it's you need to have a diagnosis that you're treating in order to be doing physical therapy. So it's certainly important, but what I want to talk about today is moving beyond that, because oftentimes that does become the distinguishing factor from one profession to another. And it sometimes it creates an unnecessary distinction for how we look at working with people. So if we can look at, again, this structural diagnosis process, maybe more in a continuum, then that will also help us understand how we can kind of bridge the gap with other professions between what I do with, basically fitness and physical therapy, trying to blend that into one as much as possible. I think we have to start with understanding how we look at structural diagnosis. So first thing I want to discuss is that sort of this Nagi disablement model. I don't know if this is still a current model that's discussed, but this is what I learned when I was in school. It was pathology, impairment, functional limitation, disability. So it was basically like a linear process, the way that we learned it too, whereas like you have a pathology, which in this case would be the structural diagnosis, and that leads to some type of impairment. So if we have a disc bulge, that's going to lead to pain, or it's going to lead to a lack of range of motion. And then that lack of range of motion or pain is going to lead to the inability to do something. So can't bend forward because of it. And then that inability to bend forward will lead to a disability that will affect you in the community, such as now I need somebody to help me do things because of this functional limitation. And now I'm less dependent in my community. So it's a nice model. The problem with it is that for me, the way it was taught was way too linear, that there was some type of linear causation, that you need the pathology to lead to the impairment, to lead to the functional limitation, to lead to the disability. So we always had to understand things from that pathology or structural diagnostic process before we thought about treating anything else. And I think the issue that we have here is that it's not a linear process, and we'll see in the research that there's really a lot of times not a very direct link between structural diagnosis and someone's complaint, which can be the impairment, can be the functional limitation, or it can be the disability, or some type of blending of all three. So to connect back to the presentation from a few weeks ago, when we looked at when we looked at black and white thinking, the structural diagnosis dichotomous thinking is that if I have pain, then I must have damage. I must have some type of damage to my structure. Or on the other hand, if there's no pain, then there must be no damage to my structure. So this oversimplifies the human experience, and certainly the pain experience, where if we find the damage, we'll find the pain. And once we fix the damage, we'll fix the pain. But oftentimes that reduces the patient's self-efficacy to believe that they can actually be part of a process to help themselves. And oftentimes it'll increase the thought of fear, because if we think about pain as damage, or if we think about the complaint that someone might have as it's being led by damage, then it makes sense to try to limit what you do, because you don't want to make damage worse. But if we've kind of flipped that model into something that we actually have to try to create more adaptability and resilience, then it changes the way we think about the process. Also, if we, instead of looking at it as we need to seek out some type of damage within inside of us and really understand from a certainty standpoint what's going on first before we take action, then it becomes a little bit more of a problem to say that I'm not sure what I have to do to get started. But if we look at it like from a movement standpoint of what's producing this symptom now right in front of us, we can usually find some things that we can do to change it, but we can also find out a bunch of stuff that doesn't bother the complaint, so we know what we can still do. So to reframe the idea of structural diagnosis, we can look at it as that not all pathologies cause an impairment, and the impairments may not be coming from a specific pathology that we have to really understand. And sometimes that's a hard thing to wrap our heads around, and that goes back to what we talked about a few weeks ago. To the idea of certainties, is that individuals feel like they need certainty, and will kind of use certainty as a proxy for correctness in some ways. Where if you feel like there's a certainty in the structural diagnosis, then we feel like well that is definitely the problem, but it doesn't necessarily lead to a direct treatment in many cases, and especially when we're dealing with movement. So we would understand that not all pathologies cause impairments, and that impairments might not lead to functional limitations or disability. So we have to really listen to what the patient or client, what's their complaint. Is it the structural pathology, or is it actually that they have a pain they want to get rid of, or there's something that they can't do that they want to be able to do better? And if we approach it from that perspective, then we can usually help them work on the thing that they can't do and they want to do better. And that's where really our specialty lies. So clinical reasoning must include context from the psychosocial realms. So we really have to educate our clients, and I think have a responsibility to educate the population as a whole, that there's an importance of all of these relationships, psychosocial, the environment, and it's not just about if I have pain, therefore there must be something damaged. And what I see a lot of times with clients is that, especially people that are in a chronic state, they're in a constant search. And I'm seeing this more and more now with those before they even really have a pain or some type of problem, that they're looking at so much online that is telling them that there's something that they're not doing, or that they're wasting their time doing one thing, and they haven't found this one root cause to all of their problems yet, and they're in this constant search to take away all the discomfort in their life. And instead of looking at it that way, I think we need to have them start a process of improvement, and a process includes a constant learning process. So instead of looking at is a seeking of the root cause of something, or a seeking of the problem that is going to be out there that's going to be easy to fix, we have to just basically look at it as maybe our pain is telling us to change something, and can we listen to it better, and can we go through a process? The nice thing about starting the process is that it can start on day one when you work with somebody. And although someone might be searching for that perfect fix for a long period of time, if we can kind of get them out of that mentality, but think of it as like, let's start the process, you could usually start that process pretty rapidly. So a little bit of research here that shows that damage does not equal pain. Would be looking at MRI studies. This first one is a systematic review that looks at disc degeneration, and all of these are asymptomatic individuals, and they have disc degeneration. So 37% of 20-year-olds, 80% of 50-year-olds, 96% of 80-year-olds, all demonstrating some type of disc degeneration with no symptoms whatsoever. Disc bulge, similar, 30% in 20-year-olds and 60% in 50-year-olds. So what that tells me right there is that, one, if you have some type of problem that would show up on an MRI that would typically be considered some type of diagnosis, it certainly doesn't have to link to pain. But it also shows that if you're a little bit younger and that shows up, maybe that is a little bit more surprising. Maybe that is a little bit more connected to your symptom. But even in almost 40% of 20-year-olds, it showed up, at least in this systematic review. But if you're older, if you're 80 years old, it would be strange not to have some of these presentations show up on images. So I think we have to also kind of look at it as there are some natural things that will show up on MRIs that you would expect to happen over time more and more. So it's often referred to as sort of like wrinkles on the inside as you get different degenerative processes over time. Where we would expect to see wrinkles on the skin as people get older, but the wrinkles themselves do not cause problems. They can lead you more susceptible to problems. Certainly, like wrinkles might lead to more fragility of the skin, and then you can get more injuries in the skin, but the wrinkles themselves are not the problems. But oftentimes, if we look at degeneration, that it does become the diagnosis that we think we're treating to help someone who comes in with a complaint of pain. So I think it's just from that perspective there's an expectation that many of the people that we work with are going to have these things on images, and that can't be the thing that leads our treatment. The same thing was shown with similar things were shown with herniated discs, and then also this last study shows that even when you're looking at MRIs, how they're interpreted by radiologists they vary quite a bit. So, and this is a case study on just a 63-year-old woman, and it was her images were interpreted by 10 different radiologists, and there were no two reports that were the same, and there was an average of 12 different findings per scan. So even when you are getting the impressions read by knowledgeable people who know how to look at these things, you're not going to get typically good agreement on what they're even finding. So similarly, damage does not equal pain. We look at pain severity does not equal damage severity. So research has shown that many individuals with severe degeneration reported no pain, while others there's minor findings with high levels of pain. Jarvik et al. In 2001 demonstrated that the degree of lumbar disc protrusion was not predictive of back pain intensity. And then Karppinen et al. In 2001 suggested that MRI is unable to distinguish sciatic patients in terms of symptom severity. So we can't be, again, using the structural diagnosis as our leader of how we're going to treat. So that leads us to another continuum where, instead of looking at things as, and again, a black and white lens, we can look at pain on one end of a spectrum, injury on another end of a spectrum. And again, they'll meet in the middle. And certainly we're not saying that structure plays no role in someone's pain, but we want to understand it maybe from more of a spectrum type perspective. So on the injury side of this continuum, we can look at tissue damage with a more identifiable mechanism of onset. So if somebody has a fall, someone has an accident, sports injury, and a lot of times, if you're a fan of sports, you've seen this a lot lately with Achilles tendon ruptures. That's certainly tissue damage, and what's happening there, but it may or may not present with pain. And oftentimes you see the athlete, has the tissue rupture, and they're not in a state of pain. They're more in a state of surprise and disbelief that their season might be over. Aaron Rodgers for the Jets a couple of years ago comes to mind, where you just realized what happened. He sat down. Certainly didn't look like he was in anguish or pain. He was just in disbelief that he kind of knew that it was over for him. So there's not necessarily a link there between how bad the damage is with a full rupture and pain. The recovery path in these cases is often more defined or time-bound as well. So again, it's still individualized, but at the same time, we are expecting that the tissue healing must be respected, and that there's going to be some type of process that we have to allow a healing process to take place. On the pain side of things, more towards certainly a chronic pain side of things, we're looking at pain as more of a protective perception. And it's influenced by multiple systems. It could be nervous system, immune system, psychology, certainly in the environment or social situations. All of those things are intertwining. And in these cases, a lot of times the onset and mechanism is often more insidious and episodic. And I would think that that's what I certainly have seen in my physical therapy profession over the years, is I see more of these cases where people aren't coming in right away after some type of specific incident. It certainly does happen, but more frequently you're seeing people that have chronic conditions or episodic pain that are up and down, and it's a lot harder to indicate what the mechanism of onset was, certainly over time. So the recovery here is often much less protocol driven, more individualized, and you're using the symptom as an indicator of what to change within the session. Right. But we also want to know, really what does provoke the symptom, and we have to really understand that. But we're going to be looking at more reducing a perceived threat of activities that were previously provocative, and we want to try to give them more function of things that are less provocative, or give them the ability to do more before symptoms are provoked. And I don't look at this as a healing process, but more of an educational process in this case, where we actually have to use pain to tell us what to do. It has to be understood. And we're actually teaching our clients how to be more skilled at looking at their pain and teaching their body how to become more resilient, but also like literally building capacity so that they have the tolerance to be more resilient with things that they previously weren't.